Hi, very good morning, everyone. We are meeting on 8th of March 2025. Welcome to the CMAAO International Weekly Meeting. Today we have Dr. Shalini Jaggi with us. She's covering a very important topic. Obviously, diabetes is something which we all know is a common problem for all the nations, all the countries, uh, all the genders, I would say. But today we are covering for women. It's a very, I would say, topic which is very close to everyone, household and every household. So today we are covering diabetes and women, need for gender-specific guidelines. To talk about this, we have Dr. Shalini Jaggi. She's a consultant and director for Life Care Diabetes Center, New Delhi, fellow, Royal College of Physicians of London, Glasgow, fellow of American College of Endocrinology, US. She's a national president-elect DIPSI, chairman-elect RSSDI Delhi chapter, serving AACE advisory board member, APAC community. She's a chair, diabetic and mental health interest group, Diabetic India, ex-national EC member RSSDI 2018 to 2022, recipient of RSSDI Women Diabetologist of the Year 2023, ACP India Community Service Award 2024, National Fellowship of RSSDI 2016 and Diabetic India 2017, National Diabetic Award Initiative Award for 2017, DEAR Academy Digital Diabetic Award of Excellence in Diabetic Care 2021. A lot of awards, ma'am. I believe I'm burning some calories. Good for my sugar, I would say. IHW Council Silver Award of for Digital Diabetic Management 2021. She's a faculty and tutor for Cardiff University, UK, and she has contributed over 65 publications in reputed national and international journals with over 45 chapters in textbook. Over to you, ma'am. Thank you so much for giving us this honor to listen to you for all the knowledge you will give me. Thank you.
Thank you so much, Mr. Saurabh, and many thanks, Seema, for this opportunity. A very good morning to all the doctors who are logged in today from different corners of the world. And as we celebrate International Women's Day today, I think I chose this topic specifically to focus on a topic which often we acknowledge but ignore. Women's health is something we've all been given birth by a woman, brought up by a woman. We all have wives or mothers or sisters, daughters all around us, and their health is very important to the well-being of our society. So what I'm going to do in the next 2 minutes is focus on how diabetes, a very common problem that all of us are seeing, is very important when it comes to a woman, and why when it comes to diabetes management actually need gender specific sensitization and care when it comes to managing a woman with diabetes. Very often, most of the guidelines, global guidelines that we have on diabetes management do not really take gender into perspective when it comes to writing out the treatment. So, if you look at all the guidelines, they'll just tell you, okay, do this, do this, do this. But what if the patient sitting in front of you is a woman in a different zone altogether? So this is what we are going to see. So we'll talk about how we require gender-specific guidelines. And let me tell you, the important question is, are we talking about feminism? No. Why are we talking? Why do we need some special considerations for women with diabetes? What makes us different from men who have diabetes? Well, we all acknowledge the fact that men and women are equal, but they are not the same. We have differences at every level, right from our anatomies to physiology to biochemistry to pathology and even pharmacology. So is diabetes different in women than men? And this is what I'm going to walk you through in the next 10 to 20 minutes. Well, if you look through the gender lens, The first and most important part we need to acknowledge and accept is the fact that experience of diabetes itself is different in women. Life cycle of a woman is very different stages of her life cycle. There are different hormones, different metabolic changes happening, and you need to actually rope them in when you decide on how you want to manage that woman at that particular point of her life stage. Diabetes has been shown to have more serious adverse outcomes in women. Plus, talk about the socio-economic, cultural context, and other social determinants. We acknowledge that there are gaps in gender specific health research and even technology. And therefore, it's time that we address the gender inequities that occur in healthcare, especially in the Southeast Asian subcontinent. So it's time that we view therapeutics with the gender lens and prioritize gender mainstreaming and benefits to actually reach out to half of the world's population with diabetes. Now, this is something that we were just discussing. The prevalence of diabetes is going up, and I don't need to tell you that, every year, every time the new numbers come, it's always more than what the previous numbers were. But if you look closely, look at the gap, the gender gap between men with diabetes and women with diabetes. We all know that more men have diabetes than women, but if you look at the figures, 2021 were 17 million more men with diabetes compared to women, but the gap seems to be fast closing. More and more women are also turning diabetic, and as you can see, the projections tell you the gap is going to narrow down to 14 million and eventually to almost 11 million by 2045. So clearly, the number of women with diabetes is on a global rise. And as you can see, all across the different age groups, especially as we cross middle age, the numbers start evening out. So as many women with diabetes as are men. And if you look at the number of people dying with diabetes, clearly, as we cross the middle age, more women are dying of diabetes or diabetes related complications once they are in the postmenopausal age group compared to men. So it's time we recognize this. If you look at the ICMR INDIAB data on the projections of metabolic disease prevalence in India, you can clearly see that diabetes, pre-diabetes, dysglycemia, hypertension, obesity, especially abdominal obesity, hypercholesterolemia, high LDL cholesterol, all the metabolic disease risk factors are definitely rising and are already very high. Now look closely at this data. This was a very good study published in Lancet. Look at the differences between the males and the females, the numbers of people who have pre-diabetes, more women have pre-diabetes than men. And if you look at impaired fasting glucose, women present more with impaired fasting glucose compared to men. Even if you look at what is very, very striking is obesity in women. Much more women who are obese than men. Abdominal obesity is a big issue. We know the pattern of obesity is very different in women compared to men. Even dyslipidemia and women who seek out treatment for dyslipidemia, how many women are taking statins versus men? The numbers are mind boggling. Low HDL cholesterol is something very, very common, especially in the postmenopausal women. So clearly, all the risk factors, the fertile soil is very much there. Now, this was a study on the sex-based differences in clinical profile and complications amongst individuals with type 2 diabetes at a private tertiary diabetes care center in South India. And clearly, it showed females had higher BMIs than males. More females were sedentary. Physical activity levels are very less in women compared to men. How many women actually take out 45 minutes every day to go out for a walk? Because you are busy playing multiple roles. You're a mother, you're a wife, you're a sister, you have work. So all those things put physical activity and self-health on the back burner. Obesity is twice as common in females compared to men. Hypothyroidism more in women. Frequency of a number of cancers much higher in females with diabetes compared to their counterparts. Dyslipidemia, poor control of diabetes, glycemic control is worse in women compared to men. And why is something that we need to find out. Well, biological sex causes sex differences through genetic and hormonal influences, affecting disease pathophysiology, clinical manifestation, and even response to treatment in females. Furthermore, behaviors, which includes their anxiety, depression, their help-seeking behavior, their health treatment, their self-management, all of this has implications to the gender. And then you have certain gender-related behaviors such as smoking, lifestyle, nutritional habits, perceived stress, exercise, all of these modulate expression of biological sex. Gender constructs actually determine disease perception and help seeking behavior, including the use of healthcare. Less women seek out healthcare compared to men. They're more worried about the husband's health or the son's health than their own health. And this triggers decision making and therapeutic responses to the treatment that is advised. Now, if you look at the drivers of diabetes in women, well, even if you put aside healthcare disparities, financial dependence that most women have on men for actually taking medicines, doing the tests, visiting the doctor routinely, urbanization, globalization have led to more obesity, sedentary lifestyle. So when you're born with those genetics, born with low birth weight, then you have catch up growth, you are at a higher risk of developing IGT, PCOS, GDM. All of these factors are very, very unique to a woman, pushing her towards diabetes. And then when they are busy in all their caregiving roles, besides all the other things that they do, I think diabetes goes back. Diabetes management suffers, and that is why we see a poor glycemic control in most women. So let us explore on why and how is it different in women. There are sex dimorphisms in body composition. There are some inherent biological differences in cardiometabolic pathways, and I'll come to that in a little while. There are gender differences in attitudes and perception of the patient. And I'll show you some numbers which will actually make us sit up and see why we have missed out this very important point. There are some social determinants of health that need to be addressed. And therefore, we all, as physicians, as doctors, need to actually look at these healthcare based inequities and biases when we have a woman with diabetes sitting in front of you. So when we come to the sex differences, of course, there are some physiological sex differences that we are all born with. So if you look closely, men have less subcutaneous fat and more visceral fat mass. Women have less visceral fat, but women have less muscle mass as well. All of these are disadvantages that women suffer. And when it comes to pregnancy, it is something very unique, which is a milestone in a woman's life, which completely changes things for her. So even the changes are not even physiological, but also other changes that happen. The gestational weight gain, which is a very important risk factor for eventually developing diabetes if gestational weight gain is not taken care of. Women present more with IGT compared to men who present with IFG. Although the diabetes incidence in females is less, but I showed you numbers on how they are fast catching up. Women get diabetes at higher BMIs, whereas men get diabetes as they age. Incidence of obesity is much higher in women compared to men. And we have a lot of women who seem to be metabolically healthy obese, but now we know that this is also a transient factor. And most of them eventually do progress to pathological obesity, resulting in a plethora of metabolic disorders. Again, depression is more in women, PCOS, hyperandrogenemia, cardiovascular disease, all of them have an impact on her health. And the most important part, her life cycle. Metabolic changes in different stages of life cycle as she transitions, right from intrauterine programming to the birth weight that she's born with, which is a very high risk factor for all the future NCDs, puberty, menstrual cycles, pregnancy, preconception care, a very important component that we really need to sit up and take into consideration for all young women coming to us. Breastfeeding, postpartum care, follow up, menopause, postmenopausal state. All of these have a different plethora of hormonal disbalance that occurs, and that is why you need to address this when it comes to managing women with diabetes at all these different stages of their lives. Right from pregnancy, suboptimal in utero environment clearly has effects on all the organ systems, as you can see here. And there's a direct link between maternal health and NCDs in the offspring. So on the one side, maternal undernutrition, maternal stunting results in a baby who's born with low birth weight. Then there's catch-up growth, and definitely the development of IGT, type 2 diabetes, and hypertension is high in this segment. And on the other spectrum, what we see in urban India, in urban places, and the rural people are also catching up fast is maternal overweight, obesity, gestational diabetes, pre-existing diabetes, excess gestational weight gain. All of these push the fetus towards fuel-mediated teratogenesis, macrosomia, eventually resulting in children who are born large for gestational age. And again, these are children who have had intrauterine programming for development of diabetes, hypertension, and NCDs. So birth weight turns out to be a very important predictor for development of type 2 diabetes, because you see this U-shaped curve. So neither the low birth weight nor the high birth weight. We need a baby with optimal birth weight, and that can happen only if maternal health is optimized. So clearly, like I said, the life cycle of a woman, if the baby happens to be a girl child and she becomes overweight, she develops PCOS, she develops IGT. As puberty progresses to adulthood, she may turn into a diabetic, or when she gets pregnant, she gets gestational diabetes. So the intrauterine programming resulting in a girl child who's born large or small for gestational age, the cycle of diabetes continues from the mother to the daughter and to the next generation. So the transgenerational risk, intrauterine programming, the fetal programming that we talk of, the origin of adult disease is in this fetal programming. And therefore, it is very, very important that prenatal development, that is where the seeds are sowed. And that is what we need to understand. So the genetics actually are loading the gun with a small for gestational age or a large for gestational age baby being born. And then the environment does the added assault. And we all know how we are seeing a huge, an explosion of obesity in kids and teens. PCOS in adolescents is a very, very common endocrine disorder affecting about 5 to 10% of the female population. It's a complex metabolic disease. You can see baseline, the background of everything, the fertile soil is because of insulin resistance. And we know how insulin resistance is linked to diabetes, to hypertension, to dyslipidemia, to central obesity, hyperandrogenism, reproductive dysfunction, malignancies, and macrovascular complications. So clearly in adolescence, the onset of prediabetes is on an upswing. Sedentary lifestyle, improper eating, increased stress levels, screen time is something which is very, very important today, especially post-COVID era. We've seen a lot of children glued to the screens. Obesity, positive family history, lack of exercise, and the hormonal changes, all of them push these girls towards an impaired glucose metabolism. And we know the link between PCOS and metabolic syndrome is very much there. Insulin resistance is the background for both metabolic syndrome and PCOS. So clearly, hyperandrogenism of PCOS is linked to several components of metabolic syndrome. There's more visceral fat, lipolysis is reduced, insulin sensitivity goes down, HDL cholesterol levels go down, and there's an increase in LDL cholesterol. All of these pushing these girls towards metabolic syndrome. And then eventually we know how insulin resistance is a precursor to diabetes as well. There is a very high incidence of IGT and type 2 diabetes in women with PCOS. Oligomenorrhea, which is a surrogate marker for PCOS, that alone predicts 2 to 2.5 fold increased risk of type 2 diabetes, especially in females who have a family history of diabetes. So this is where we need to take note and understand, when you see an adolescent with PCOS sitting in front of you, you need to actually take measures there and then to prevent progression to IGT, to prevent progression to GDM once she gets pregnant, and to eventually prevent progression to diabetes if measures are not taken early. 35% of patients with PCOS have IGT, and 10% develop type 2 diabetes by the time they are 40 years of age. So clearly, we need to understand that the conversion rate from IGT to diabetes is 5 to 10 times higher in women with PCOS compared to women who do not have PCOS. So friends, this is where we need to sit down and go back and look at the unique strategies that we need to address when we have an adolescent or a young woman with PCOS sitting in front of us compared to a young man with diabetes. Lifestyle changes should be aimed at weight loss, metabolic well-being. You need to avoid the effects of hyperinsulinemia in a woman, because this is something which is very unique to a woman. All these factors lower the risk of metabolic syndrome, type 2 diabetes, cardiovascular disease. Psychological support, emotional well-being, mental support is very, very important. You need to lower the risk for GDM in PCOS girls. Pharmacological management has to be as per the guidelines, as per whatever guidances we follow in our part of the world. But it has to be gender sensitive to this very important aspect, because you simply cannot ignore this. Moving on to cardiovascular disease in women. Again, when it comes to heart disease, men and women are not equal. We all think that more men die of heart attacks, but I'm sorry. Cardiovascular disease amongst women is understudied, under-recognized, underdiagnosed, undertreated. And women are so often underrepresented in clinical trials, and show you numbers to back that. We need to understand that 35% of all deaths in women worldwide are caused by cardiovascular disease. So clearly, there are major disparities when it comes to cardiovascular disease between men and women. It's time we move away from bikini medicine when it comes to women. Women also have a very high risk of heart disease. However, more likely we are attributing their symptoms to non-cardiac causes, which often results in a delay of medical treatment. Certain risk factors such as diabetes, hypertension, depression exert a greater overall risk for cardiovascular disease in women. However, women are less likely to enroll in secondary prevention programs, they remain underrepresented in clinical trials, and they are less likely to be willing participants in clinical research trials. And we've all seen that. Like I said, CVD in women is often underdiagnosed and undertreated. They'll come with vague symptoms of back pain, neck, jaw pain. We think it is anxiety. We push it under the cupboard. Palpitations. Non-invasive testing is much having less predictive accuracy. There is a higher incidence of silent MIs in women. So if you look at this data on sex differences in the risk of vascular disease associated with diabetes, you can clearly see that women with diabetes are having a higher risk for coronary heart disease, for strokes, for vascular dementia, even for CKD and cancers compared to men with diabetes. Often we ignore these non-specific symptoms of cardiovascular disease in women, and this is something that has to change. This is data that I was talking about. Underrepresentation of women in cardiovascular clinical trials. Look at this percentage of women who actually have the disease and how many of them are enrolled. We all talk about cardiovascular safety. When it comes to diabetes management, we have trials with, the newer trials coming out with SGLT2 inhibitors, with GLPs, and all the other trials with all the different therapies. But if you look closely, how many women were enrolled in those trials? So how do we extrapolate that something that is good for the men would be same for women? Because I'll show you some data which will again change your perspective. Now, diabetes increases coronary heart disease risk by 4 to 6 fold in women with diabetes compared to only 2 to 3 fold in men with diabetes. And there are all these women specific risk factors: the hormonal milieu, pregnancy induced hypertension, gestational diabetes, preeclampsia, preterm birth, all of which actually have a very moderate to strong association with all these CVD, all these factors that I'm talking about. This is the Nurses' Health Study, which clearly tells you that the relative risk of MI or stroke goes up as diabetes is diagnosed and women develop diabetes. So clearly this tells you diabetes changes the cardiovascular disease. And then women lose their normal female protection from cardiovascular disease as menopause occurs and as the hormonal changes occur. So clearly 50% greater risk for CVD in women. 3 to 7 times more women with diabetes are likely to develop or die of heart disease compared to men. IHD and stroke still represent a major cause of mortality and morbidity in women, and we simply think that men have more stroke. If you look at the severity of heart disease, again, if you look at men versus women, if you look at the deaths within 1 year of the first MI, much higher in women than men. If you look at sudden deaths with no previous symptoms, 63% women have a sudden death compared to 50% men. And then if you look at the numbers of within 6 years of recognized MI, percent who will have another MI, percent who will have a stroke, experience a sudden cardiac death, or disabled with heart failure, you will clearly see more women having much higher severity of heart disease compared to men. And that is why way back in 2003, Time magazine actually realized that heart disease is a woman's biggest worry, and it's not bikini medicine. It's not the reproductive system. It is not the breast cancers. Look at heart failure. We all have been talking about the newer drugs for diabetes management. We've talked about heart failure benefits. How is heart failure different in women compared to men? Well, men present with reduced ejection fraction heart failure, whereas women are more likely to develop preserved ejection fraction heart failure. If you look at the highest risk of developing HFpEF, clearly female gender is a very, very important risk factor for incidence of preserved ejection fraction heart failure. I talked about strokes. Clearly, diabetes in women is associated with an increased risk of strokes. So women with stroke will appear to become more severely ill following a stroke, and these sex differences have profound implications for effective prevention and treatment of stroke. Again, diabetes, the excess risk of stroke associated with diabetes is significantly higher in women than men, and it is independent of the sex differences in all the other major cardiovascular risk factors. So friends, clearly, if you look at the risk factors for cardiovascular disease, of course, the well-established risk factors of diabetes, hypertension, dyslipidemia, obesity are definitely there. But you need to acknowledge the sex-specific risk factors: menopause, gestational diabetes, hypertension in pregnancy, preterm delivery, PCOS. All of these increase the cardiovascular risk in women. And then you have some under-recognized risk factors: socioeconomic deprivation, poor health literacy, environmental risk factors, abuse, psychosocial risk factors. It's time we acknowledge the effects of these risk factors, which is very, very crucial to understanding and preventing cardiovascular disease, especially in women with diabetes. I showed you, if you look at the major cause of death for females, it's not breast cancer, it is cardiovascular disease. So, again, let's step back and understand that it's prudent to keep cardiovascular prevention in mind when managing women with diabetes. And the strategy here, when you write out your prescription for diabetes management for a woman who has type 2 diabetes compared to a man, is to avoid drugs that can cause CV harm because of their increased risk compared to men. And therefore, it's important and prudent to prescribe drugs that offer cardioprotection. Again, the dual burden of malnutrition and obesity. Look at the numbers of metabolic syndrome. All these studies have clearly shown that women are gaining more weight. Changing lifestyles, pregnancy, menopause, reduced physical activity, and unhealthy eating patterns and choices are to be blamed besides the genetics. If you look at the prevalence of generalized obesity, this is data from India, ICMR INDIAB study, clearly showing you north, south, east, west. More women are obese than men. Even before the clock starts ticking earlier in women, even, when they are converting from pre-diabetes to diabetes, even before they become pre-diabetic, you can clearly see the Western New York study showing you that there are sex differences in endothelial function. So, the biomarkers of endothelial dysfunction, E-selectin, ICAMS, fibrinolysis, PI1, all of these have been shown to be increased in women who develop pre-diabetes compared to the controls. So definitely the clock starts ticking much earlier for women than men. Again, if you look at the pathophysiology of diabetes, abdominal visceral adipose tissue is more strongly associated with insulin resistance in women than men, and obesity and metabolic dysfunction in women reduce the inherent sex hormone protection from cardiovascular disease. So as a woman progresses from normal glucose metabolism, they take a longer duration to develop type 2 diabetes. So they are in that dysglycemic pre-diabetic zone for a much longer time. They have a greater deterioration of cardiovascular risk factors than men. And as they start gaining weight, we know our subcutaneous fat stores are much more. All the weight initially goes into subcutaneous fat stores before it starts spilling over to the visceral adipose tissue. So they need to gain much more weight than men to reach the same level of abdominal visceral fat. And therefore, women have a stronger association of abdominal visceral fat with insulin resistance than men. And eventually, possibly, they have more adverse cardiovascular, cardiometabolic consequences of gaining visceral adiposity than men, putting them at a higher risk. Pregnancy, something which is very, very unique to a woman because she is the one, her body takes the brunt of a pregnancy. Complications of uncontrolled diabetes, I don't need to go. Congenital anomalies, if glucose levels are not controlled in early pregnancy, and then if she gets gestational diabetes or develops diabetes or dysglycemia as pregnancy progresses, polyhydramnios, stillbirth, fetal macrosomia, difficult labor, metabolic complications, worsening of complications in pre-existing diabetes. All of these factors put preconception care at the forefront. Pregnancy has to be planned, especially in women who are obese, who have PCOS. the risk of gestational diabetes is much high, and women who have pre-existing diabetes, a review of all medications for diabetes. So when you have a woman who is in the reproductive age group, it is important we sensitize her to this. A girl who gets diabetes at an early age needs to be counseled on the risks of an unplanned pregnancy, especially when glucose levels are not on target, to have better maternal as well as neonatal outcomes. So, education, physician directed medical care, screening for complications, all these concepts of preconception care have to be woven into our management of all women with obesity, diabetes, metabolic syndrome. Insulin, safety of medicines before and during pregnancy is very important. So you cannot really prescribe the same anti-diabetic agents that you were prescribing to men, because in pregnancy we know that most of the oral drugs are contraindicated. Of course, in India, DCGI has recently approved metformin, but then metformin also crosses placenta. A slightly increased risk of prematurity or small for gestational age was shown with metformin in infants who were exposed to metformin in utero, but largely metformin has been found to be safe. And thus, in Southeast Asian countries, where access to insulin, acceptability of insulin is an issue, especially in milder degrees of dysglycemia or gestational diabetes, metformin probably could be a drug of choice. However, if there is intolerance to metformin or if there is contraindication, if you are seeing IUGR, if there's preeclampsia, if you are seeing fetal hypoxia, definitely metformin should not be used. Of course, insulin remains the gold standard for pregnancy. It is safe, it does not cross placenta. Of course, regimes need to be individualized based on the glycemic profile of the woman. All teratogenic medications have to be avoided in pregnancy. So if she's on ACE inhibitors, ARBs, you need to change over to the safer alternatives. You need to stop statins. You need to review all the concomitant medications, start her on folic acid. If she is planning a pregnancy, to prevent the neural tube defects, give her low dose aspirin at about 12 to 16 weeks of gestation. So I'm not going into the entire gamut of pregnancy management with dysglycemia. But what I want to talk about is a woman in the reproductive age group. Many times pregnancies are unplanned, you know. So you need to sensitize these patients, especially all these high risk women, have to be told very clearly that an unplanned pregnancy is a red flag for these women because of all the adverse maternal and fetal outcomes that are associated. Again, a woman with diabetes who is breastfeeding. This is again where you need to talk about not giving oral agents that are not found to be safe, because we know most of the oral agents are excreted even in the breast milk. So clearly, the therapy has to be individualized based on the level of dysglycemia. Often we continue insulin till she stops feeding. Metformin is the only drug that is used in breastfeeding. All the other oral antidiabetics need to be stopped. So once they stop lactating, it is advisable to transition to oral drugs if they have pre-existing type 2 diabetes. Now, menopause, all the hormonal changes that happen in menopause, testosterone levels going up, SHBG levels coming down, androgenicity happening, estrogen levels completely getting depleted. So increase in body fat, reduction in skeletal muscle mass, central deposition of fat, with visceral obesity going up, inflammation. All these again lead to a gamut of hypertension, cancer, coronary heart disease, obesity, health issues, weight gain in midlife, central distribution, increasing insulin resistance. All of them impact glycemic control as well as cardiovascular health of that woman with diabetes. Osteoporosis. Don't forget about bone health. Often we'll treat diabetes, we'll treat hypertension, we'll look at their cholesterols, but we just don't look at their bones. Osteopenia, osteoporosis, so common in women who are postmenopausal. So all of these factors have to be factored in when you are looking at a woman compared to how you look at a man. Anti-diabetic agents conducive to weight loss or weight neutral are to be used. Caution to be exercised with beta zones. I'll show you that. As a woman turns postmenopausal, see this. HDL cholesterol levels completely declining, LDL levels going up, even MASLD, NAFLD, the protection that estrogen offers to fatty liver disease completely goes away in menopause, putting her at a higher risk of progressing MASLD, steatosis, and fibrosis. So clearly, as she ages, the risk of MASLD associated complications goes up. So when we manage diabetes in postmenopausal women, we need to actually understand all these different challenges And accordingly, all the considerations for management have to rope all this in. Look at this risk of fractures with glitazones. Of course, we know glitazones have an increased risk of fractures, but look at the fractures in men. Relative risk is only going up one-fold. Look at fractures in women, much higher. So, the best would be abstaining from prescribing glitazones to women. They get more water retention, they get more fractures. Then moving on to gender differences in diabetes attitudes and adherences, depression and anxiety, much more in women, twice as common in women with diabetes compared to men with diabetes. And then the added assault of menstruation, pregnancy, miscarriages, postpartum, all of these additional stresses make diabetes control go down. Diabetes distress, much higher in females than males with diabetes. Dependence, financial dependence for disease management. Women, very few women are actually self-reliant. Yes, a lot of women now have started working, they are becoming financially independent, but rural India still has a lot to help. Even in urban India, a large number of women are still homemakers and they depend on their husbands or their sons for healthcare, bringing them to a doctor, taking adequate treatment, buying medications, doing the necessary tests is something that women definitely are way behind compared to men. So if you look at, caring for spouses, caring for children, self-care in women is very, very redundant. Now, this was a very interesting article that said type 2 diabetic women are not smaller than men, smaller type 2 diabetic women. They are not small type 2 diabetic men. There are sex and gender differences in how women respond to anti-diabetic drugs compared to how men respond. And even complications, microvascular complications, neuropathy, nephropathy, much higher in women compared to men. Worsening of retinopathy in pregnancy. How many of us often look at the retinas during preconception or when the woman comes to you in pregnancy? This is something that we all need to rope in into our diabetes management for women. This was a very interesting article that talked about the gender differences in cardiovascular outcomes with SGLT2 inhibitors and GLP-1 receptor agonists in type 2 diabetes. We're flooded with the newer agents for diabetes management. So, three primary CVOTs with SGLT. We've all heard about empagliflozin, dapagliflozin, and canagliflozin. All the three trials showed a significant reduction in MACE and heart failure outcomes. But if you look closely, the reductions in MACE happened in men, but not in women. However, if you look at the 7 CVOTs with GLP-1 receptor agonists that we looked at, they demonstrated a significant reduction in MACE in both sexes. So clearly, what led to this is something we still need to find out. Was it because of inadequate statistical power, because of underrepresentation of women in CVOTs, or does it really reflect a true gender difference? It still remains to be established. So, if you are looking at reduction in MACE as the primary reason for prescribing an SGLT to a woman, well, data actually goes contrary to that. Women did not really show a significant reduction in MACE compared to men with SGLT2 inhibitors. And this is still being explored, and maybe we will be wiser when we have more data coming in. What happens to adverse events, side effects with anti-diabetic agents? Well, more women come with adverse events than men throughout body organs and drug classes, especially gender-specific reporting rates, especially with the newer drugs, SGLT2 inhibitors, GLPs, and even glitazones are much higher in women. Women dominated the reports of class-specific adverse events with newer agents, more UTIs and GTIs reported by women in SGLT2 inhibitor category compared to men. Women getting more edema with glitazones compared to men. Women presenting more with glitazone-induced fractures and hyperglycemia in insulin users, more in women than men. What are the genders differences and barriers that women face in relation to accessing type 2 diabetes care? This was a very interesting systemic review in the Indian Journal of Public Health. And if you look at the personal barriers, lack of time due to caregiving role, Women giving less priority to their overall health, lack of education, health problems, socio-cultural barriers, lack of family and social support, health system barriers, failure on our part to provide adequate health information. She'll tell you, I have anxiety, I have palpitations, and you say, oh, you take too much stress. You're very worried with the family. Stop, start focusing on your health. We do not let her understand that maybe it could be a signal of early cardiovascular disease. Lack of sensitization of health professionals towards all these important factors of women's health, unsupportive nature of health professionals. I think all these need to be changed, besides all the common facts that we talk of: economic barriers, psychological barriers, negative outlook, superstition, geographical barriers, financial dependence, lack of insurance, physical activity. Much less women will go out for a walk compared to men. Therapeutic inertia, which is the physician's failure to begin or intensify indicated treatment, very common in treatment of NCDs. And percentage of therapeutic inertia is much higher in women. Clearly, you can see more women are not given intensification of treatment when it is required by us compared to men. So sometimes the elephant is very much in the room, standing in the middle of the room, but we are not acknowledging that. And that is what has to change. So, friends, I think in the last half an hour, I have actually tried to convince you that diabetes in women is different. It is difficult, it is disabling, often dismissed, and is associated with more deaths. So we need to actually step back and see, do the current recommendations for diabetes management identify the need gaps and unique challenges for diabetes in women? We actually need to have strategies that are sensitive to a woman's life cycle and the unique challenges and limitations that she faces at different stages of her life cycle, right from birth to growing up, attaining puberty, obesity, weight gain, PCOS, pregnancy, the reproductive age, gestational weight gain, gestational diabetes, development of diabetes, menopause, dyslipidemia, cardiovascular health, bone health, background of all this: adipose tissue dysfunction, metabolic syndrome, insulin resistance. These factors need to be addressed. Do the current recommendations address the psychosocial concerns, her anxiety, all the different factors that I talked of? So if you look at all the algorithms we have for diabetes management, they just put everyone together. You have cardiovascular disease, do this. You have high risk for renal disease, do this. You have established cardiovascular disease or CKD, do this. What if you are a woman? Are we actually looking at that? If you look at all the global guidelines, the gender is completely missing. If you look at this diabetes risk score that we all have been blindly following, given by the ADA, look at this. Are you a man or a woman? If you are a man, your risk for diabetes goes up by 1 point. But if you are a woman, 0 points. This is something that probably needs to change, and science is giving us evidence that maybe it is time that all these risk calculators are revised based on all the evidence that has emerged, because we need to tweak the recommendations. If you have a woman in the reproductive age group sitting in front of you, somebody who's planning a pregnancy, you need to follow the preconception, pre-gestational diabetes guidelines. If there is no contraception and pregnancy desired, you need to recommend contraception. You need to discuss preconception care, family planning. If she is not planning a family, you have a choice of different agents that can be given. If she's planning a family, if she is in that preconception zone, you need to change the diabetes management completely. If she's menopausal, acknowledge bone health, acknowledge genitourinary symptoms, acknowledge the increased risk of atherosclerotic cardiovascular disease that she has, acknowledge the increased stroke risk, vasomotor symptoms, all of this. When you look at any algorithm, it's time that we add on these gender specific risk factors, assess her status, avoid medications that may be unsafe in pregnancy, because I told you a lot of pregnancies are unplanned in our part of the world. Acknowledge her bone health. Medications that increase risk of fractures and cause bone loss, especially in postmenopausal women, glitazones, avoid them in postmenopausal women. GTIs, UTIs, Acknowledge that, ask for it, because SGLT2 inhibitors, we're using them left, right, left, and center. So many times I have seen women, who have been given SGLT2 inhibitors, they're visiting their obstetricians regularly for GTI and UTI, because the obstetrician is not primed that this probably could be the reason why they are getting it. So all these factors are very important. So when we have a table that tells us the profiles of anti-diabetic medications and tells you hypoglycemia, this drug is good, this drug is bad, weight, this drug is good, this drug is bad, GI side effects, cardiovascular benefits, bone benefits, all these factors, why not add a column there for gender and say what is the effect of that drug for a woman, which is different from its effect in a woman. For example, metformin, we know it can induce ovulation. So a woman in the reproductive age group has to be told, that if you are on metformin, ovulation goes up. So if you're not planning a baby, if you don't want to expand your family, contraception becomes very important. GLPs, SGLTs, DPP4s, AGIs, none of them are indicated in pregnancy. So if you are planning a baby, you need to stop these drugs. Again, fractures, heart failure in women, especially postmenopausal women, very high with glitazones. Do we find a mark there in all these tables? No. Again, all the sulfonylureas contraindicated in pregnancy. So I think we need to have those labels there in the guideline recommendations itself. So friends, I would like to end that a woman's life cycle makes her very, very unique. And it is time that we recognize and accept these gender specific differences. And it's time we practice gender specific medicine. We need gender sensitive strategies to deliver quality care to half of the world, to all these women with diabetes through different stages of their life course. And with that, I think I'll stop sharing, and I hope I have hammered the fact home that diabetes management in women has to be viewed from a completely different perspective. Look through the gender lens, look at the age group, the life stage that she is in, and accordingly, you need to rope in not only diabetes management, look at her as a whole, the risks that she is at, and address all those factors when you treat a woman with diabetes, when compare, which is going to be a little different. You just need to tweak a little. You don't need a you don't need a new guideline. You just need to tweak those guidelines and make them gender specific. Thank you so much.
Wow. Thank you so much. I think a very powerful and a very insightful presentation. Uh, Quite knowledgeable, quite an eye opener. Especially, I think a lot of people in this world is living in illusion, I would say, and especially, I think some of the key points which you mentioned, I think they're they're very knowledgeable, I would say. They're very eye openers. So, with this note, we would like to open the forum for question answers. And I would also like to announce if somebody in the audience who is watching us from Facebook, LinkedIn, YouTube, and everywhere, they want to join for a question answers round right now, they can join in at the Zoom session quickly. The Zoom session ID is 818-8591-1572. I repeat, it's 818-8591-1572. I know there is a little delay, so you might not be able to join till the time the session is over, but if you can quickly join, we have a question answers round over here. Okay, on the audience, anyone with the questions? Dr. Bukhari, you want to say something?
Okay, thank you so much. I have no question because no need to ask any question from a very such a beautiful lecture from the Shalini Jaggi. I will request you to talk this lecture, and thank you very much, Dr. Saurabh, on my Pakistan forum. If any Sunday we call, only as a pathologist, because I know we have made some a formula for the patients in the diagnosis, because I cannot comment on your lectures. Very beautiful lecture, especially. And that is why I am inviting you on the Pakistani forum. If you give me email, and I will next time. Okay.
Honest.
As a diagnostic, as a pathologist, we have made a formula. I think it is formula for everyone, because it is becoming a pandemic in Pakistan. Around about 3.3 million out of our 250 million patients are suffering from diabetes. In every home, every fourth person is diabetes. Okay, I have A, B, C, D, E, F, G, H. A for attitude. We have to change the attitude of the patients. Not only the gender, not only the gender difference, because it is killing both difference. No doubt the females are very precious, but everyone is precious. A, we have to change the attitude of the peoples towards ignorancy. They usually ignore their diseases. That is why it becomes more complications. Then is the B. B, you have to check regularly your blood pressure and your blood sugar. This is the very important things to tell your patient, either male, female, or anything. If you do regularly check up this thing, the blood pressure and the if suffering from the diabetes, if the blood pressure is rising and complete, you control it, that will reduce the complication. Then the C is the cholesterol. It is as you discuss this, the lipidemia and all other things are. Usually LDL is very, very important. As a pathologist, I say that if you want to reduce the complication of diabetes, the patient should reduce. It is not difficult to reduce. The D is especially your diet style. That is very important to leave the things that causing the diabetes. Very important things. The people are now going in intermittent fasting and other things. You have to reduce the cereal. You have to reduce. So diet is very important to things. And E is the exercise, 30-minute exercise, indoor, outdoor. You told that it is difficult for the female. I usually in the morning, every day in the morning, I go on the walk. But when I say to my wife, she's no, I am sleeping. So it is also attitude of the female that they do not do the exercise. Otherwise, there's no problem to coming outside. That is the exercise. Then is very important is thing is that that is the F. So these are actually important things that how to think. And then is the G, gratitude, thankful to Allah that he has given us the health and something else. Then is the H. HbA1c is very important to control this. If it is different effect in the male and the female gender. That is why I think as a pathologist, as I am not a physician. So A, B, C, D, E, F, G, H, these are the principles. If you tell our patients, I think we can reduce this pandemic. Thank you so much.
Thank you, Dr. Bukhari. Dr. Angelica, you want to say something?
Yeah, I just also would like to thank Dr. Jaggi for a beautiful presentation, very insightful. And I want to congratulate her that on a Women's Day, that the lecture she gave is actually so fitting for a day as today. And I would also like to thank her for bringing in the socioeconomic situations and understanding the world where a woman is living in. We see, we as physicians on a daily basis, we try to say to the patient, do this, exercise, walk, eat the right food. And you say a lot of things, but it's not that easy. It's not that easy to change that environment where a woman is the caretaker and caregiver to the family. And I find in a lot of lectures and seminars, there's not enough emphasis on the role of a female in her society or her social standing. So again, I want to thank you for that. And I noticed it. And yes, it is true. It's difficult to get women to understand that this beautiful big baby is not a sign of how wealthy you are, but it's actually a sign of the dangers that child might face around about the age of 20 going forward. So thank you so much again for highlighting this, that it's not only underweight babies, but also overweight babies that poses a risk going forward. Thank you so much again.
Dr. Jaggi, we have a question. Pregnant women with diabetes can pass the health risk to the newborns?
Sorry, can you come again?
The question is, does pregnant women with diabetes can pass the health risk to their newborns?
Yes, a pregnant woman with diabetes, if the glucose levels are not controlled during pregnancy, can have adverse outcomes. The risk of diabetes, if the child is born low birth weight or high birth weight, goes up in this baby because the baby gets primed. The intrauterine gestational programming that we're talking of, the changes that happen in the baby, the priming that occurs to the baby, if this baby is born more than 3.5 kilograms birth weight, we celebrate the birth of a healthy baby. We say, oh, the child is healthy, the birth weight is 4 kilograms, 4.5 kilograms, but this is a baby who is already hyperinsulinemic. So I think this is a child, if it is born large for gestational age, if the child's birth weight is more than 3.5 kilograms, essentially because of maternal overnutrition, gestational diabetes, or uncontrolled hyperglycemia, then this child is at a higher risk of developing diabetes, obesity, metabolic syndrome. It does not mean that a father with diabetes will not pass on. The genetic risk of diabetes is passed on by both mother and father. So that still remains. That's a different factor altogether. But if the mother is diabetic, early pregnancy, if the glucose levels are not controlled, risk of congenital anomalies is very high. Neural tube defects, sacral agenesis, caudal regression, all of these are much higher. And if she develops gestational diabetes and we do not manage it well, we need very tight glycemic control in pregnancy. If she develops GDM and we do not control it well, the hyperinsulinemia in the baby's pancreas also get primed. And this child, when this child is born and undergoes catch-up growth, or if the child is already born obese or overweight, this child then leads a sedentary lifestyle, starts putting on more weight, gets into all these environmental risk factors. So the epigenetic changes that have happened in the child will manifest as obesity. And that is why we see a lot of teens who are obese today. Presents as, PCOS if it is a girl, or obesity if it is an adolescent boy. And these children eventually turn pre-diabetic and
Yes.
diabetic and have a high risk of cardiovascular disease. So that is why pregnancy is a very low hanging fruit to actually sensitize these women. So I think my message would be, if you see a woman with gestational diabetes or a woman who's already diabetic and planning a pregnancy, start talking about maintaining ideal body weight. Start talking about maintaining exercise, eating a healthy diet to prevent fetal programming. Because that is a very important factor why we are seeing so many people turning diabetic. Because children are being programmed intrauterine, and then when they are born with this kind of a genetic priming, the environmental assault that happens, the sedentary lifestyle, the weight gain that happens, this predisposes these children to all these entities that we are talking of. So yes, pregnancy is an important risk factor, and therefore optimizing maternal health, looking after her cholesterol, her blood pressure, her weight, her glucose levels prior to conception is very important. If we are able to optimize the mother's health prior to conception and during pregnancy, the risk of all these problems will disappear. Genetic risk, you cannot do anything about it. The genes will be inherited both from the father's side and the mother's side. But all these primings that can occur in pregnancy need to be addressed. And yes, that is why NCDs, if you want to control or prevent NCDs, you need to focus on the fetus for the future. Very important.
The follow-up question on this is that during the pregnancy, you said controlled diabetes is very important. So is it advisable to take medication during the pregnancy when she's like 8 months, 9 months, or 5 months pregnant? Is it okay, or is it naturally needs to be done? Like, because a lot of people are.
No. This is a very important topic. It's a lecture in its own.
I know.
Preconception planning and then managing diabetes in pregnancy. But in very short, if the woman is already diabetic before pregnancy, if she is type 1 diabetes, no doubt she has to continue her insulin and has to increase the insulin doses according to the glucose demands of pregnancy. Basal bolus insulin continues. Insulin is considered safe in pregnancy because it does not cross placenta. A very important factor in pregnancy is when a woman gets pregnant, we'll tell her, eat this, don't eat this, because this can harm the baby. Similarly, for medications, a lot of medications are teratogenic for the baby. So therefore, you need to be very careful on what medications we prescribe during pregnancy. If she is already pre-existing type 2 diabetes, even before she plans the pregnancy, all oral drugs need to be stopped. Only metformin has been found to be safe. So if it is safe, it is tolerated, metformin may be continued, it is better we transition her to insulin. Insulin does not cross placenta, so it will not cause fetal harm. So and the kind of tight control for glucose that we need, fasting glucose has to be between 70 to 90 in pregnancy. It is tighter than what you need for type 2 management. 2-hour postprandial has to be between 100 to 120 all through pregnancy. Because if glucose level exceeds 120 and crosses 140, the fetal pancreas is going to sense this glucose and become sensitized and programmed for diabetes. So that is why very tight glycemic control is required, and insulin has to be given if glucose levels are not controlled with diet, lifestyle, or metformin. So in pregnancy, similarly, if she is on statin, you need to stop the statin. Similarly, if she is on ACE inhibitors or ARBs for blood pressure control, you need to transition to the healthier options. Labetalol, prazosin, all these are found are safe. So I think it's important that pregnancy management is very, very important. You need to review medications. You need to screen for complications. Risk of progression of microvascular complications in women with diabetes increases in pregnancy. So I think pregnancy management is again a very tightrope walk, but tight glycemic control, tight blood pressure control is very important. And that is why preconception only we tell them to start insulin, so that, when she gets pregnant, the same insulin can be intensified and tight glycemic control is maintained to prevent adverse neonatal and fetal outcomes.
And I think I will probably request my team to get this in a session again. Dr. Akhtar, Dr. Prakash, Dr. Sajjad, anyone else has a question?
Yeah. Good morning, Sharab and Dr. Jaggi. It's a very enlightening, very extensive women empower in diabetes. This is really very helpful. My question is there any progress pancreatic transplant for the diabetic patient? And the other thing, what the social determinant will affect when we diagnose and the same patient go back to the same society? How does minimum cost effective management, with your experience? Thank you.
Talking about the first question that you asked on pancreas transplant, well, pancreas transplant, islet cell transplant, renal transplants, a combined pancreas and kidney transplant, all of them have been tried for type 1 diabetes treatment and cure. But unfortunately, none of these have actually led to 100% control, because even after transplant, the recurrence of type 1 diabetes has been seen. So I think this is still something which is being explored and is not really a definitive management for type 1 diabetes cure. For type 2 diabetes, we know it's a completely different pathogenesis. It is essentially insulin resistance, along with declining beta cell dysfunction, and along with all the different factors like in role of incretin hormones, role of adipose tissue, a lot of factors that go into the pathogenesis of type 2 diabetes. So therefore, for type 2 diabetes, I think the prevention is through weight loss, through medical nutrition therapy, through lifestyle management, exercising, because genetics you cannot control, but environment definitely you can control to prevent progression to type 2 diabetes. Moving on to your second question, the second question was on cost effective management of diabetes. So yes, sir, in our part of the world, Southeast Asian subcontinent, cost plays a major role in deciding what treatment we write out for our patients with type 2 diabetes. Because, our compared to the West, where the government pays for healthcare, here healthcare is essentially from our own private pockets. So not every patient can afford the treatment and the investigations that we write out. So I think we need to be very sensitive as doctors when we are seeing the patient and what socioeconomic status he belongs to. So if you have a patient who can afford the best of treatments and money is not a cost, of course, the benefit of GLP-1 receptor agonists, the benefit of newer agents, benefit of newer analog insulins can be given to this patient. But for a patient who needs a more cost-effective treatment, who belongs to the lower socioeconomic strata, or for a woman who is not financially independent, for a woman who depends on her family for her healthcare needs, and where cost is a restraint, you need to still go for the cheaper options. And that is why you will see that compared to the West, where GLPs, SGLTs are being commonly prescribed, in India, in Pakistan, in all these countries, especially in the lower and middle socioeconomic strata, we still see sulfonylureas and metformin, glitazone still being prescribed often because they're more cost effective and they are as efficacious as all the other drugs. So yes, cost plays a very important role in deciding the prescription that we write out, because compliance and adherence to therapy is very cost dependent. You write out an expensive insulin or an expensive treatment, your patient may not tell you, but the patient may be skipping medications, the patient may not be taking it as advised. Compared to that, it is very important that when we write out a prescription, it has to be a mutual decision between the doctor and the patient. So the patient has to be able to afford the treatment that you are writing, so that he can adhere to therapy, he can be compliant, and then only your treatment will work. So yes, cost sensitivity is again a very important factor, especially in patients who are paying out of their pockets for their healthcare costs.
I think, Dr.
Thank you
Shalini,
so much.
this is a very, very good point. In India and I think everywhere else, a lot of treatment do suffer because of the cost. Even for the insurance company, they do cover the hospitalization, but when it comes to a doctor visit, which is almost like, probably less than like minimum 2,000 to 5,000 charge, people do skip that, second follow-up or third follow-up because they don't want to incur that cost, and rightly, because it is not covered by insurance as well.
Absolutely.
So, even the medication, if it is expensive, they try to find a cheaper version, or they probably do something which is,
True.
they skip the part. So a lot of
True.
treatment suffer because of the cost part, and I think government should do something where they should include the insurance and everything, like how it happens in the West, where they do co-pay and everything gets covered in the insurance. I think that is an entire ecosystem which will improve not only the health of human, but it will be more of follow-up and more of rigorous checkups which happens. So I think just the last point which I want to make, and it's more of a question or it's more of a query. It's like it says that, is it true that eating sugar does not cause diabetes, but if you are already a diabetic, then you should avoid sugar, and it is more of a eating the junk food which causes sugar rather than eating a sugar itself?
100% true. A lot of times when we diagnose diabetes and we tell a patient that you have diabetes, he'll say, oh, but I don't eat sugar. Or maybe, yes, I got diabetes because I've been having a lot of sweets. This was wedding season, this was festival season, so we binged on sweets and that is why I have developed diabetes. No, eating sweets, eating sugars does not cause diabetes. Diabetes is caused by a plethora of factors. I told you: overweight, obesity, poor lifestyle, insulin resistance, adipose tissue dysfunction, incretin axis dysfunction. So all these factors. But eating sweets, eating all these high carbs is calories. Calories makes you gain weight. So when you already have a dysfunctional beta cell, when you already have a background of insulin resistance, when you already have a family history and the genes that can lead to diabetes, activation of these genes will occur. You challenge your body. When you're eating a sweet, why do we tell patients with diabetes not to eat sweets or to eat in moderation? Is because already you have a dysfunctional beta cell, you already have insulin resistance, and then when you consume a high carb diet or you consume sweets, your beta cells are not able to produce the amount of insulin that is needed to suppress that glucose level and keep it down to normal. And that is why you will see a worsening of glucose levels on consuming sweets or on consuming high carb diets. So yes, directly you will not see an etiological reason of eating sweets linked to onset of diabetes. But yes, on a background of insulin resistance and beta cell dysfunction, eating sweets, junk food, carbs lead to worsening of insulin resistance and worsening of glycemic control, and therefore we forbid or we tell patients to eat all these things in moderation. So mindful eating is very important.
Wow, thank you so much. I think we are already over time, 15 minutes over. If we don't have any other questions on the floor, I would like to close this session with a note that it was a very, very good weekend for us to have something thoughtful, and we should follow whatever we can do for control diabetes. Men should go and talk to their wives and see what can be done. But any take home message before we can close the session?
I think my take home is eat healthy, follow a good lifestyle, see that your weight is in check, see that your ABCs, your A1C, your blood pressure, your cholesterol is in check. That
Thank you.
only can actually help you lead a healthy lifestyle. You can prevent diabetes. Even if you have diabetes, see that you manage it well and prevent complications associated with diabetes. And for women, it's time we start prioritizing our health. Be more sensitive to your healthcare needs, because if you are healthy, you can keep your family healthy. Healthy cooking starts from home. Healthy eating starts from home. Healthy lifestyle starts from home. And for all the men, I think it's time that we sensitize our women and support our women in their journey all throughout their lifestyle, so that maternal health, a woman's health, is also given equal importance as is a man's health, so that both the parts of the world, the male and the female, can coexist together in a healthy world, in a healthy society, and globally we can have better health. Thank you.
And my F stands for follow up.
Absolutely.
Absolutely.
Regular follow up is very important.
Thank you so much.
So, with this note, we would like to end a powerful session. It was an enlightening session for us. With this note, we'll close the session. Thank you so much. I sincerely thank Dr. Shalini Jaggi for joining this forum, for giving us insightful knowledge, and to spend a weekend with us in the morning. So, thank you so much. We'll invite you for another session with another topic on diabetes. And I think the more we talk, the more we know, and the more questions we have. So thank you so much with this note, and thank you,
Sir,
everyone.
one invitation from me, my side in Pakistan.
Thank you. Thank you. Pleasure and honor.
Absolutely.
Thank you so much. It's
Thank
been
you
a
so
great
much.
interaction. Many thanks for all the appreciation, and I hope my messages are taken well and implemented. Thank you so much.
Thank you.